Today we'll be talking about chromosomal abnormalities, the common ones, so that we are all familiar. Like I've said several times that as fetal medicine people, you have to have the knowledge of the subject that you are practicing. And the only way to have the knowledge of the subject you are practicing is by learning. And this is the process of it, learning. Issues, learning the common abnormalities that we do encounter. So these are the commonest abnormalities that we have encountered so far, and that are encountered globally as well. We have trisomy 21, trisomy 18, trisomy 13. We also have got the sex chromosomal defects, which include 45X. This is monosomy X or Turner syndrome. Then we have the triple X, the 47 triple X, which is fairly a normal variant in most cases. The 47 triple X. I'll describe how these babies, what will become of these babies later when I talk about the sex chromosome abnormalities. Then we also have got the 46 XY. And the 47 WXY and the 47 XYY. Then we have the Triploidy. Triploidy could be the 69 triple X or the 69 WXY. So these are the commonest defects, and I will just go through some of the commonest features that you may encounter with these defects. But before we do that, let's look at the screening. The screening method for chromosomal defects starts in the first trimester when we measure the nuchal translucency. I think by now all of you have been exposed to the nuchal translucency scan. The nuchal translucency is the basis for screening for chromosomal abnormality, the ones that we do between 11 and 13 weeks plus 6 days. This is very important, and this is very key, and this should not be ambiguous to any of you. If you have not yet been converted and you still don't believe in first trimester screening, then there's a problem. This is a message that you should tell everyone who cares to listen to you, your friends, your relatives, your colleagues who decide to have babies. You should tell them that the most important scan to go to is the first trimester scan, so that you can be screened for trisomy, for Down syndrome, Edwards, Patau, and all those other chromosomal abnormalities I've mentioned. So the nuchal scan, which happens between 11 to 13 weeks plus 6 days, is the most important scan in pregnancy care, because this is where risk assessment is done. And remember, it is not just the aneuploidy that we screen for. We also screen for preeclampsia in the first trimester. So for us, the majority of our clients are Black women, and preeclampsia is very common in Black women. So it is advantageous for anyone who is pregnant to book in first trimester and have the 11 to 13 week scan. Then in later pregnancy, we use the syndromic pattern approach to try and screen for chromosomal defects. Some of you may wonder, why do we measure the ventricles in first trimester, even when they look like they are normal? Because we want to pick up in second trimester, because we want to pick up the mild ventriculomegaly. Because you know that mild ventriculomegaly is a soft marker for trisomy 21. Some of you may wonder, why do we measure the knuckle fold, the knuckle fold thickness? Why do we measure the cisterna magna? Because they are markers of Down syndrome. Why do we look at the choral plexus and say there are no cysts? Because they are markers. Why do we measure the renal pelvis, even when it doesn't seem like there is obvious dilatation of the renal pelvis? Because mild ventriculomegaly, hydronephrosis, is a marker for Down syndrome. Why do we measure the long bones, the humerus, in particular the humerus? Most people probably don't know, why are we measuring the humerus anyway? Because a short humerus is a marker for trisomy 21. And why do we do the weight in second trimester and comment if the weight is normal or small? Because fetal growth restriction, early onset fetal growth restriction, which happens in the second trimester, is a marker for chromosome abnormalities. So you should be very clear with this, that when we see the women, most of those who have jumped or skipped the first trimester and were doing the second trimester scan, we are not just looking for major defect, we are also screening for chromosome abnormalities using the markers. So be aware of this, because some people may wonder, why do I have to do all these things? Why do I have to be competent in doing the anomaly scan? Why should I measure every parameter required by FitaMed when you say somebody's come for anomaly scan? This is why it is important to conform to the protocol of the anomaly scan. When you say you are doing anomaly scan, no page or no line in FitaMed should be left unfilled. If somebody wants to leave anything unfilled, you have to remind them that you have not measured the cisterna magna. The cisterna magna needs to be measured because it's a marker for Down syndrome, for chromosome abnormalities, as you will see. So please remember this, it's very important, because most of our women do not present in first trimester for the 11 to 13 week scan. So that means the best opportunity for us to catch them is during the second trimester scan. Those who fail to come for the second trimester scan, again in third trimester scan, we make a serious effort to look for the same markers. NASA trisomy 21, what features are common with trisomy 21? Because the question is, the syndromic pattern approach, when we scan a baby, how do we end up telling the woman that, look, your baby is likely to have trisomy 21 or trisomy 18 or trisomy 13 or Triploidy? We use the markers, which have been studied extensively, and people have seen a great association between these features and the specific chromosomes. So for trisomy 21, nasal hypoplasia, a small nasal bone, or a small nose, a flat nose, is part of the markers. Increase prenasal skin thickness or prenasal edema. When you measure the skin just on the forehead here, I think some of you have seen us measuring this skin in front of the forehead, and we said the skin in front of the forehead is increased or thickened. We are looking for features of trisomy 21. When we measure the knuckle fold thickness, we'll look for markers of trisomy 21. When we look at the heart to look for cardiac defects, we are looking for features of trisomy 21. Cardiac defects include AVSD. AVSD is the most, the presence of an AVSD means the risk of trisomy 21 is more than 1 in 2 is 50% or more. So that means the likelihood ratio is very high there whenever we see arterioventricular septal defect. VSDs can also be associated with trisomy 21. Intracardiac echogenic foci is also a feature. Duodenal atresia, echogenic bowel, mild hydronephrosis, shortening of the femur or the humerus. Sorry, I didn't put the humerus, slash the humerus there. So shortening of either of them. We do not combine them because they are dependent of each other. So it's either shortening of the femur or shortening of the humerus. The sundown gap. Sundown gap, we're saying there's an increased gap between the big foot, the big toe, and the second toe. This is why we make that image of the underside of the foot, the footprint image. That's the purpose of the footprint image, so that you can look for a sundown gap. And clinodactyly. Clinodactyly means the fifth finger is bent inwards. It is bent inwards due to hypoplasia of the mid phalanx. Yeah, phalanx. So the fifth finger is bent towards the fourth finger. That's clinodactyly. You may wonder what it is. That's clinodactyly. Then the mid-phalanx hypoplasia of the fifth finger, I've already mentioned that. So this is why we want to see the 5 fingers and possible to see them outstretched, to see the 5 fingers outstretched so that we can check for hypoplasia of the mid-phalanx or the middle bone of the finger. You know, the finger has got 3 phalanx, you know, demarcated by those creases. So while talking about the middle one, in the small finger, that's the mid-phalanx. That the bone won't be visible on ultrasound if it is hypoplastic. So these are the features common to trisomy 21. However, if you see these features, don't go on and tell the mother that your baby has got trisomy 21 because you have seen mild hydronephrosis. No. You wouldn't go on and tell the woman that, look, your baby has got trisomy 21 because there is nasal hypoplasia. We are saying these are the features that suggest. We will go through the risk calculation, of course, the counseling to say, what do we do if we see these features? But you don't see one feature and conclude and tell the woman that, look, your baby has got trisomy 21. We are saying the features are suggestive of trisomy 21. Hence, we need to counsel the woman. We need to readjust the risk if she had already had the risk in first trimester, and probably offer further testing because the features are suggestive. We'll come to the management to say, what do you do if you come across these features? But please don't see one feature or even 2 features and then suddenly tell the woman that, oh, your baby's got trisomy 21, because it could be wrong. Trisomy 18. What are the features? Strawberry-shaped head, coral plexus cyst. Strawberry-shaped head, what is it? It is a small head. It looks very funny. Strawberry, let's see if I can mimic a strawberry here, or just try to draw a strawberry to just give a good idea. I didn't put the, right. So normally you see a head that looks, sorry, a head that looks like this. It's a rounded head, kind of. It's a rounded head. It's too rounded. It's a small rounded head. The strawberry-shaped head. The coral plexus cyst, I think most of you have seen them, and we've also demonstrated when we were doing the CNS abnormalities. Then the absent corpus callosum, we also mentioned this in the CNS defect. Those who are not clear, you can go on our YouTube channel, Fetal Medicine Foundation Zimbabwe, and watch the CNS defects videos. Then the enlarged cisterna magna. All of us should know what enlarged cisterna magna by now. Then fascial cleft, and it's also in the videos. Fascial cleft, we did the face recently, and micronathia, we covered that. Nacoedema is the same as in Down syndrome, in trisomy 21. Then the heart defects are also present. Diaphragmatic hernia, some of you have seen it, those who participate in the fetal defense clinic. Diaphragmatic hernias, the esophageal atresia, the exomphalus, single umbilical artery, renal abnormalities, echogenic bowel, myelomeningocele, growth restriction, and shortening of the limbs. And radiaplasia. Radiaplasia means there is missing radius. This is why we always check the bones of the forearm, the radius and the ulna. We are looking for radiaplasia. Every image is a purpose. So don't wonder why and say, why do people have to make an effort and check that there are 2 bones in the leg? Can they be missing? Yes, they can be missing in case of radiaplasia. Then we have the overlapping fingers. And overlapping fingers, and let me add and say clenched fists there. They have clenched fists. Then we have talipes or rocker bottom feet. Talipes, the same as club foot, right? The talipes. The rocker bottom feet is slightly different, but people always interchange these names and call it club foot, all of it. So these are the features of trisomy 18. Then trisomy 13. presents with the holoprosencephaly. I think most of us have already seen the holoprosencephaly, microcephaly, fascia abnormalities, cardiac abnormalities, enlarged and echogenic kidney, then exomphalos and post-axial polydactyly. So yeah, so these are the features of trisomy 13, trisomy 13. Then triploidy. Triploidy presents with there can be two types of triploidy. The triploid means it's a triplication of the chromosomes. Normally humans have got 46 chromosomes. That is normal. They have 46 because they get 23 pairs. They get 23, half of the 23 from the father and 23 from the mother. But if one of the parents donates a whole set of chromosomes, like 46, then we end up with a baby with 69. So that's triploidy. This donation can come from either the father or the mother. The whole sperm can fertilize half of the egg, right? Because the egg has to divide from 46 to 23 to form this haploidy. So if it is from the mother, it's called digynic triploidy. If it is from the father, it is called didendric. If it is from the mother, from the father, it doesn't form a baby, but it forms a molar, what you call the molar pregnancy. Molar is just an abnormal proliferation of the placenta tissue. I think most of us have seen what a molar pregnancy is. So that's part of the triploidy, but in this case, it is the whole sperm that is fertilized the half of the egg. Then if it happens that is the mother who contributes the whole egg without the egg having divided, it contributes the whole set of chromosomes 46, then it becomes a digynic triploidy. The digynic triploidy, a baby is formed. So there is a placenta there. The placenta is thin, but it is of normal consistency, and the pregnancy actually persists into third trimester as to didendric, where there is, in most cases, they bleed, these women, before 20 weeks. They rarely go beyond 20 weeks. Here and there they may, but it's not common. The fetus demonstrates severe asymmetric growth restriction, mild ventriculomegaly, that is in digynic, where the mother contributes a whole set of chromosomes. There is mild ventriculomegaly, there is micronathia, there is cardiac abnormalities, myelomeningocele, syndactyly, and hitchhiker-toe deformity. Syndactyly is the fusion of the fingers, what you call webbed fingers. If two fingers are fused together and they can't be separated, that condition is called syndactyly. Syndactyly, you cannot separate the two fingers. They are webbed fingers. That's the other name to say webbed fingers. So remember that. Then the hitchhiker-toe deformity, where the toe is looking upwards. So the big toe looks upwards. That's the hitchhiker-toe deformity, which we see on we have triploidy, the digynic type. So remember this, very important, the digynic type was the one which you are likely to see, because the molars are normally picked up in the GAN side, on the GAN side of things. Then the monosomy X or Turner syndrome. Normally they present with a large cystic hygroma. I think by now we have all seen cystic hygromas. And generalized edema, I think we had a tennis yesterday, it's Sally. Is it Sally or Para? I can't remember, but we had a tennis this week. Then we have generalized edema. Then we have mild pleural effusions and ascites, and also cardiac abnormalities and osteokidneys. Normally, the picture these babies give is quite typical, as described here. So that's monosomy X features. Then we have the other sex abnormalities, like the triple X. The triple X, when I started, I said these are more like a variant of the normal, for sure, in most cases, there's nothing on scan. We have managed patients, I think this was in the private sector, we had the triple X. The baby was absolutely normal. But for the ladies, for the triple X, these are ladies, and they are normally tall. They are tall and lanky. They participate in sports. They end up playing basketball. They have a special skill. They may have very soft, lax bones, and they do sports. They are like super women, the triple X. This is the message we tell the parents, because the parents normally come to us very worried. Then we told them we are going to give birth to a superwoman with super extraordinary abilities. They may have some fertility issues, but normally in modern times there is always a solution to this for fertility issue, because they can always go IVF. Their eggs may tend to mature a little bit early, because they'll be going more towards the Klinefelter kind of syndromes, but they tend to mature early, and they may be advised to conceive earlier, or to have their eggs preserved through cryopreservation, which is quite common nowadays. Then for the males, normally there are not much features for those with double XY and the X double Y. Yeah, so this is not a problem. You may bump onto this when you do karyotype sometimes, and you bump onto this kind of chromosome, but on ultrasound, there's absolutely very little to say. This is a summary of the defects. This table is found in the 11 to 13 week book, or the first trimester screening program, which is on our computers, the blue application. It's a very good table in that it allows you to triage the chromosome abnormalities. Whenever you are scanning, you can take a glance and say which features are more common on the baby that you are scanning, so that you know whether you are dealing with trisomy 21, trisomy 18, or trisomy 13, or triploidy, or tenors, so that you can cancel the patients with the most likely condition which you are suspecting on the scan. So it's a very important table. You can check it out in the first trimester screening program, which is on the computers, the blue application we use to calculate the risk for Down syndrome in first trimester. So this table is there. So just take a glance, it will help you as you scan. So in terms of the management, if you do scan and you suspect through those features that we have mentioned, that you are going to see certain features for specific conditions, whenever you see a defect or a soft marker which suggests a chromosome abnormality, look for more features. Don't stop there and walk away and say, I've seen an increased knuckle fold on this baby, and you walk away. You look for more features, for associated markers. I'll explain why you have to do that, because one marker may not be enough for us to order further tests. However, if there are multiple abnormalities, let's say you've checked and there are multiple abnormalities, in most cases, the risk for chromosomal defects is substantially increased, and fetal karyotyping should be considered. Here we're talking of major defects. So if there are multiple fetal defects, major defects, the risk for chromosomal abnormalities or genetic syndromes is very high. And these women, we should offer them karyotype so that we can establish the actual condition. The reason for doing this is that sometimes the outcome of the pregnancy depends on the underlying chromosome abnormality. For example, if the baby has got trisomy 18 or 13, these three are lethal. So irrespective of whether the defect can be corrected or not, the fact that there is an underlying trisomy 18 or 13 makes the condition lethal. So this helps in the counseling. This is why offering invasive testing is important. Then the next issue, whenever we offer karyotype, we want to be able to counsel expecting parents on the potential recurrence risk. And we also want to give them the closure. People always ask this question whenever I tell them that there is an underlying abnormality on your baby. They want to know what has caused it, because knowing what has caused it will allow them to get the closure that everyone wants. So invasive testing is part of trying to bring the issue to a closure, because if somebody knows that there's trisomy 18 or trisomy 21, they can rest assured that, look, this is a non-disjunction chance that has happened during the baby formation. Otherwise, our people will resort to other means of trying to find out the reason why their baby is abnormal. So that is why it is important to offer carrier if we know that the condition is lethal. For example, holoprosencephaly, allobolopprosencephaly, we know it is a lethal condition, but establishing whether there is trisomy 18, trisomy 13 or not, will help us in recurrent risk counseling. If it is an isolated condition, holoprosencephaly, the recurrence risk is about 10%. If it is due to an underlying chromosomal abnormality, it's about 1%. And if it is due to a genetic syndrome, then it's about 25%. So expecting parents want to know all this information so that they know what are their chances. So that if they are to abandon natural conception, they go for PGT via the they go to via the IVF route for pre-genetic testing, then they can do that. So that is why it is important to know. And also, yeah, I think I've explained all the reasons why it is important to know the carrier type, even if the defects are many and the condition is lethal. Well, some may argue and say, why do you have to subject these women to further testing when you know that the defect is already bad? It helps us because you want to know the recurrence risk, and the couple will find better closure if they know that there was an underlying genetic syndrome. Otherwise, they will resort to witchcraft and say we're bewitched by the aunt or by the mother-in-law or somebody else. Right. So if there's a minor abnormality, minor abnormalities, what are minor abnormalities? For example, we have clinodactyly, or we have synodactyly, or we have polydactyly. In this situation, these are not major defects. Nobody will say they are grossly disabled because they've got a bent finger or they have an extra finger. It's a minor abnormality, or probably you just saw a mild ventriculomegaly, which will later on probably resolve on its own, or you just saw an echogenic foci in the heart. These are minor abnormalities. The heart is structurally normal. All we are seeing is an echogenic foci. So what do we do? What we do is we have to risk reassess. Let's say somebody's been seen in the first trimester and we've given them a risk. Let's say their risk in first trimester was 1 in 20,000. Then they come back for the anomaly scan and we know that there are some markers of Down syndrome or Edwards or Patau. What we have to do is we have to recalculate the risk. How do we recalculate the risk? For us to recalculate the risk, we have to understand this table, which is in the 11 to 13 week scan book from the FMF. This book is available for free online. If you go to the Fetal Medicine Foundation website, on the 11 to 13 week scan course, you can download this book. There is this table here. This table tells us something called likelihood ratios to say what is the likelihood chance that the baby has got Downs or any other defect if you pick up this a certain marker. The secondary markers or the soft markers, they can also be found in normal babies at a certain frequency. So if you look at the first, the second and third column here, you see that in babies with Down syndrome, 33.5% of them will have increased nuclear fold. Babies who actually have got trisomy 21, they've been tested, they've trisomy 21. If you do check for nuclear fold, you find an increased nuclear fold in 1 in 3 of them. However, when you check normal babies, you find increased nuclear fold in 0.6% of the babies, of normal babies. I'll give an illustration of the nuclear fold. What I'm saying applies to the rest here. So what does it mean? What it means is that, what is the likelihood ratio, the positive likelihood ratio then, that if you pick up an increased nuclear fold, the baby is likely to have Down syndrome. To get that number of the likelihood ratio, you divide the percentage of babies who are likely, who have Down syndrome with an increased nuclear fold, with the percentage of babies who are normal with an increased nuclear fold, to end up with a positive likelihood ratio of 53. So the positive likelihood ratio is 53 for having an increased nuclear fold. Then we go on now to say of having trisomy 21. But the soft markers are not interpreted in isolation when you are doing an anomaly scan. This is why you have to check everything. For you to get the likelihood ratio, if we only have nuclear fold, to say we only have nuclear fold and everything else is normal, how do we come up with a likelihood ratio that will allow us to change the a priori risk that we obtained in the first trimester? So what we have to do now is to, let's assume that there is no short humerus, no short femur, no hydronephrosis, no echogenic foci, no echogenic bowel, and no major cardiac defect. So we are going to multiply this 53 by the negative likelihood ratio of these other ones, because these defects are absent. So I'm going to multiply with these numbers. So when we multiply with these numbers, we're going to end up with 9.8. This is the likelihood ratio of an isolated nuclear fold. So if we assume that the woman had a first trimester risk of 1 in 20,000, that means we're going to divide here by 9.8. And this will probably give us a risk of what? Let's say of about 1,000, close to 1 in 1,000, right? So that's the new risk now, based on just an increased nuclear fold. This is the basis of our counseling of the mother, to tell them that, look, your risk has greatly changed and it's now 1 in 1,000. Then it will be up to the mother to say, how does she understand the risk? Because 1 in 1,000 is still a low risk. But if we assume that the first trimester was 1 in 2,000, we remove another 0 there, and we have this nuclear fold, then her risk will be 1 in 100, which will put on the borderline, and she becomes high risk somehow. And now we have to tell the mother that you are high risk. We have to test you for Down syndrome. We can offer a NIPT because Down is easy to NIPT is very good at screening for Downs. So we can offer a NIPT, or we can offer invasive testing because her risk has changed. But if we take a scenario whereby we probably have 2 markers, let's assume we have both increased nuclear fold and a short humerus here. So what it means is that we are going to multiply these 2 and the negative likelihood ratio, because these other ones are absent. So we're going to use the negative likelihood ratio here, and we're going to multiply with all this negative likelihood ratio. Probably we might end up with a combined likelihood ratio of probably 15 to 20 there. And it is the same figure that you are going to use now to divide here. Let's say it's 32, the likelihood ratio. So I'm going to divide 32 into this to get the new risk. I just used an example here of an echogenic focus and hydronephrosis. So you can see that an echogenic focus and hydronephrosis, they are combined together, and we multiply with the negative likelihood ratio of the others which are absent. We are going to end up with a likelihood ratio of 8.42, and we will divide into this a priori risk from first trimester, and we'll get a new risk of 1 in 2,335. It's still a low risk. That means you can offer the couple the option of doing nothing because their risk is low, because these are soft markers. So in brief, if we see just a short humerus on its own, this is the likelihood ratio, and you have to divide it into priorities. The NACA fold on its own, this is the likelihood ratio. Then if you see hydronephrosis, it is 1. It's not going to change the risk, because remember, any number divided by 1 doesn't change. The same with the echogenic focus in the heart. It's not going to change the risk. When it's 1.1, just as good as 1. The short femur doesn't change much. It's 1.6. While echogenic bowel may change the risk, and a major cardiac defect will change the risk as well. A major defect, not just cardiac defect, will change the risk, because dividing by 5 will certainly change the risk much. So this is how we play with the features that we find when we are screening for chromosomal abnormalities in second trimester. Okay, so I think this is the end of my presentation on chromosomal abnormalities and how we do risk recalculation or risk readjustment in second trimester. I think I'll end here and open the room for questions. Good time to end. Maybe before questions, let me remind you that we have the placenta meeting next week. I hope most of you have registered. The program should be flighted today. So please take note of this, that the program will be flighted today. And yeah, those who are not sure they've access to internet at 101 Chinamano, we're going to be beaming the presentations from there. So you can come to 101 Chinamano and attend the meeting from 101 Chinamano. I don't know if there are any other questions, but otherwise, if there are no other questions, we are done. Tawanda Jakada, you've raised your hand. Please go ahead and ask the question. If you can't, you can type, Tawanda. I can read your question if you do type your question.
Okay, so let me type the question.
You can actually say out the question because you can speak.
Okay. My question is regarding the placenta meeting. I'm having challenges with registering for the placenta meeting.
Guys, may you address the challenge? I think that admin can hear you. Can you guys get in touch with Tawanda and try to address the challenges bring out? Thank you for bringing that out, Tawanda. Probably many people are getting that challenge. Guys, let's interrogate or investigate and find out why are people having challenges in registering, because it shouldn't be like that. Should be straightforward. But make sure you are you have an active Zoom account, because what we are trying to avoid is we are trying to avoid ghosts. Because sometimes ghosts disrupts meetings. So make sure you have a Zoom account. Each of you should have a signed in Zoom account where you can be identified, where you are known, where you have logged in with your email and have been signed into Zoom. That is very important. Without that Zoom account, you can't register, because it is a webinar. It's not an open Zoom kind of platform. So please, let's take note of this. I think by now, all of you should have Zoom accounts because you've been joining the webinars. So those who don't have, just rectify that. Make sure you have a Zoom account which works for the meeting. Any questions on the chromosome abnormality? Remember, this presentation will be available on YouTube. Watch it over and over again. This topic is done, and we are assuming that learning has taken place. So we do not want to see people get lost whenever you ask them to check, to go to the table and check for and do the syndromic approach and see which syndrome is more likely. Because we'll ask you to say, can you please check these features and tell me which syndrome is more likely? So please don't appear lost and appear like you don't know what we are talking about. So on your own free time, watch this presentation again so that you understand more and more. And you can always ask questions at any time, either in the group or in person when you meet me. Yeah. Otherwise, enjoy your